Okay, now we're going to talk about Chapter 39, Pediatric Variations of Nursing Interventions. Let's talk about the informed consent. The reason for an informed consent is to inform child or parents of the risk, benefits, alternatives of a procedure, and it's used for major surgeries, minor surgeries, diagnostic tests that pose risks such as the use of an IV contrast for CT, blood transfusions, the insertion of chest tubes, or procedures such as a paracentesis or thoracentesis. Consent is given by parents or legal guardian or mature and emancipated minors. Adolescents' consent and confidentiality. Let's talk about medically emancipated conditions such as STIs, mental health services, alcohol and drug dependency, pregnancy, and contraceptive advice can be cared for without the consent from parents of adolescents. Okay, so for preparation for procedures, in young children, toddlers benefit from having things that are familiar to them with them at the hospital when you're prepared to have a procedure done. Such items should be allowed to travel with them to the site of the procedure, especially for surgical procedures, until anesthesia has been provided. Be careful not to allow preschoolers to see equipment except when it will be used on the child. Also, for preschoolers, it may be helpful to use dolls to demonstrate or explain procedures to the child. For the adolescents, explain the procedures or expectations to teens. Because the removal of clothing items such as underwear, pajama pants may be traumatic for children, allow them to keep such items on prior to a procedure. Remove unnecessary clothing items after anesthesia has been administered to avoid adding unnecessary stress. See pages 1132 through 1134 for guidelines for preparing children for procedures. See Table 39-1 for suggestions for selecting non-threatening words or phrases to use when preparing a child for a procedure. In preparation of a surgical procedure, remember to assess for family history of sudden fever and myotonia with surgical procedures. Also, remember that all children are susceptible to malignant hyperthermia. For the school-age child, explain procedures using medical terminology. Use simple diagrams for procedure explanations. Allow the child to play with safe equipment that they will see before, during, and after a procedure. You want to review causes of post-op vital signs alterations. This is located in Table 39-3, page 1139. Okay, a brief review of the care of the hospitalized child. Maintain skin integrity. Use appropriate nursing interventions to prevent skin breakdown, such as the use of draw sheets to move a child in the bed. Bathe the child and wash the hair as needed to promote hygiene. Maintain oral hygiene. And of course, feed them. Question parents and children as to their favorite foods. Attempt to accommodate child's preference to encourage adequate intake of food. Give high-quality foods or snacks when the child complains of being hungry. Dehydration is always a concern. Offer and encourage adequate intake of appropriate fluids such as Pedialyte. Fever control. Tylenol is a drug of choice. Motrin for kids greater than 6 months of age typically will alternate Tylenol and Motrin. Monitor for febrile seizures. Remember, fevers are common with viral illnesses. Also keep in mind that antipyretics work with a fever, but do not work with hyperthermia. For hyperthermia, treat the child with cooling measures such as a tepid bath. Discontinue tepid bath if the child becomes chilled. Safety. Keep them safe. Keep crib rails up at all times. No dangerous items left in the cribs, such as sharps of any kind. And then wheels on cribs or beds, make sure they're locked at all times. And remember to use standard precautions as needed. Okay, we're going to talk about some nursing interventions. As we're going through these, look at pages 1145 to 1162 of your textbook. Collection of specimens. Be sure to use age-appropriate methods. For instance, the use of a needleless syringe may be used to aspirate urine from cotton balls or 2x2 gauze placed in an infant's diaper, whereas a child that is potty trained may be able to provide a clean catch specimen with the parent's help. For Foley catheters, use 2% lidocaine lubricant if available. For medication administration. For bitter tasting medicine, you may mix the medication in a small amount of something sweet that the child likes, such as ice cream, pudding, or grape jelly. When administering liquid medication to an infant, use a medication syringe or needleless syringe to administer the medication into the side of the mouth. Note that you can use an empty nipple that is not attached to a bottle for liquid med administration also. Be sure the hole in the nipple is large enough for the infant to suck on the medication to get it out. Do not mix the medication in with a bottle. There is no way to tell how much medication the child actually takes that way. See the nursing alert on page 1169 for optic, otic, and nasal medication administration. Venipuncture. See page 1154 for guidelines and atraumatic care. CPT, beneficial for children with chronic lung disease with thick mucus such as CF. CPT is usually performed just before meals or 1 to 1.5 hours after meals. Review the procedure for CPT. Remember, when using your hand, be sure that it is cupped, not flat, and you are doing it over a gown or article of clothing for protection. Restraints. As always, use the least restrictive method of restraint possible. And for oxygen administration, remember O2 is dry and must be humidified. Delivery of O2 should be uninterrupted to maintain appropriate O2 concentration. For infants, oxyhood or nasal cannula may be used. CPAP or CPAP may be used as well. Nasal cannula may be used to administer CPAP if needed. Facial mask must be appropriate site to be beneficial. Croup tints, mist tints are no longer standards of practice. Okay, so let's talk about some pediatric procedures and IV administration. You want to see pages 1158 to 1159 for evidence-based practice for appropriate site, technique, needle size, and dose for IM injections in infants, toddlers, and small children. Table 39-6 shows appropriate IM injection sites for children. Page 1162 for IM administration of medication. Table 39-7 discusses IV cath flushes for lines without continuous fluid infusions. Table 39-8 discusses a comparison of long-term central venous access devices. Figure 39-14 venous access devices shown here in the top left corner of the slide. And then see pages 1168 through 1169 for central venous catheter site care. Let's discuss discharge planning. Remember, it starts on admission. You want to provide parents with written instructions regarding dietary restrictions, how to assess manage pain, possible complications or symptoms to report, as well as medication teaching for medications the child is being discharged with. Discuss potential behavioral problems that parents may see in their children after returning home that were not present in the hospital and are not normal for the child. Help provide overall guidance for parents to help transition the child from hospital care back to home regarding the level of care the child will be receiving. So here are a few pediatric pearls of wisdom. Provide age-appropriate explanations. Provide hands-on experience with equipment. Be confident in your care and tell the child exactly what you expect from them. Give them choices when appropriate. Don't ask if you can do something. Tell them that you're going to do it. Provide appropriate distraction. Allow the child to express their feelings. Provide positive reinforcement. And think up fun ways to get the job done. See box 39-1, page 1137. And then keep the parents involved and present. Okay, so for examples, preschoolers may talk incessantly. evolving from me to seeing others' viewpoints, use magical thinking to solve problems and make sense of their environment. They may deny pain or other problems through magical thinking. May be dependent on security objects and items. Handle with care and do not lose my blankie, my teddy. Preschoolers are also very aware of surroundings. Always include the child in conversations and concrete thinking. Early or young school ages, like 6 to 10 years, they have early acquisition of skills and achieves a sense on competency. Failure to do this may lead to a sense of inferiority. Consciousness is forming and peer group interactions are highly influential. Concrete thinking, very early. Engage about schoolwork, sports, arts, projects, and encourage and praise efforts. For the late school ages, ages 10 to 12, they care about computer games and sports. And then we have adolescents, and they think beyond the present. They're logical, they use reasoning. Sometimes they are capable of abstract thinking. They have group identity, it's paramount, and risk-taking is common secondary to peer pressure. Remember, the frontal lobe of the brain is not fully developed in adolescence, and it results in decreased inhibition. This concludes Chapter 39.